Good morning, everybody. It is very honor for me to have presentation in the most famous hepatobiliary center in India. So when I talk about ABO-I, usually it takes at least 1 hour, but it's very hard for me and to you too. So this slide is the contents of which I presented in the day before yesterday in the 8th annual conference of Liver Transplantation Society of India. I start the presentation from B-cell immunology and go into the long-term tolerance after ABO-I liver transplantation. So I should have talk from an introduction, but today I just skipped the introduction. So please follow me. This is a well-known pathways of antibody production. A is the T-cell dependent pathway. B is T-cell independent pathway. Usually, even though we do not have the injected with a different type of red blood cell, but already we have the antibodies against the different type of blood antigen. Usually, as you know, is immunized through the food from the child food, and the pathway is the B1 cell pathway. So T-cell, this pathway is T-cell independent. And another thing is the T-cell dependent pathway is a B2 cell. It's a B2 cell pathway also have two pathways. One is non-germinal center B cell. And the other one is germinal center dependent B cell pathway. The memory B cell played important role. This is the slide of B cell desensitization. In a basic regimen of desensitization or against the ABO or antigen consists of rituximab 2 weeks before transplantation usually, and we start tacrolimus and Cerecept 1 week before transplantation. And if the titer is very high, we do the plasmapheresis or, if possible, absorption treatment. And we used to do the splenectomy, enhance the depletion of B-cell immunology activity. But after usage of the rituximab, we quit the splenectomy in the usual situation, and we just follow the routine immunosuppression. Before the era of rituximab, we add the immunosuppression, we add the immunosuppression, we add the immunosuppression. A patient die with severe AMR or infections. So after rituximab, we can reduce the total immunosuppression that we can avoid the infectious complication. This is the slide, the rituximab and Cerecept and tacrolimus. In mice experiments, Professor Oda in Hiroshima University revealed that the tacrolimus can deplete the B-cell development to the plasmablast. And this is the reason why we use the tacrolimus before the transplantation. The Cerecept, as you know, deplete the B-cell at the plasma cell activity, and rituximab deplete B cell, including memory B cell. this is the regimens, which I told you already. This is a slide of a case. This patient was PBC, and the titer was very low at that time. Maybe it is 8 something. And at that time, I had the opportunity of rituximab, but because the patient had very low titer, I hesitated to use rituximab because at that time we have no experience. Just I prepared. I did not have as the first case, but the B cell. At that time, I followed the B cell after the transplantation, and the B cell increased the blue line, and the memory B cell increased day 5. So I gave the rituximab after transplantation. Although the B cell decreased, but the titer, antibody titers increased, jumped up more than 500. Although I started the plasma exchange, the patient developed severe AMR and died. After this case, I use rituximab all patients in ABO-I, even though the titer is low. But this patient showed me that the memory B cell works together. It means the AMR after transplantation is related to this pathway in which the memory B cell works. And in the desensitization regimen, we just deplete the pathway without T cell, and deplete or decrease the antibody before the transplantation. But the antibody before transplantation can act on the target antigens on the surface of the epithelium, but we can reduce the antibody and avoid that reaction. But after transplantation, the patient have a chance to produce the antibodies through the memory B cell activation. This is the reason why we have to decrease even the memory B cell too by rituximab. How to treat the AMR. So basically the first choice is steroid pulse after the liver biopsy, when we doubt the beginning of AMR, such as fever and increase of liver functions. This is a report of the successful success of treatment of AMR using bortezomib from Kyoto group. As you know, the bortezomib destroys the plasma cell. This is the figure of their article. First, they give rituximab day 6, and because the patient did not improve, they add the bortezomib day 9 and day 12. And the antibody decreased, of course, after the plasma exchange, but the CD19 decreased, and the patient improved. This is a very informative case, and we have to deplete the B cells, activated B cell and activated plasma cell, both when we treat the severe AMR. Issue changed. This is the slide of a current situation of ABO incompatible transplantation in Japan. The right panel shows the survival of patients 18 years old or older after 2013. So we began to use the rituximab 24. So almost all patients are treated with rituximab before transplantation. So now we don't have no significant difference among the blood type combination. I moved to the tolerance. So we had a case. The patient was 12 years old and type group O. She underwent a transplantation 10 years ago. And then the local doctor who take care of my patient called me. She has low titer of the antibody. I agree that. So I follow all patients, but he wants make some experience using her blood to show the mechanisms. So we do that together with him. So and also I work with Professor Odan. Again, he come back again. He's at Hiroshima University. He's a surgeon and immunologist. And this is the antibody. The donor blood type is A. Okay, and dark circle or square. This is the type B. IgM, IgG. So 2 years after transplantation, patient produce the antibody against the antigen, type B, but the titer of antibody against the type A reduced 2 years later. So the patient have the hyporesponsiveness, especially to that donor type, blood type. This is the experiment. We use NOD skid mouse, and we engraft with human PBMC of volunteer O, volunteer A, and the recipient A2O, and then sensitized human blood type A and measure the antibody titer. And the right panel, the mouse engrafted with type O PBMC produced antibody, but type A did not, of course. But interestingly, recipient PBMC, the mice with recipient PBMC did not produce antibody. Next study is Dr. Ueda. He also the mentee of mine in Kyoto University. He followed up 75 patient, type O patient who underwent ABO incompatible transplantation. This slide shows the change of anti-donor antibody titer in blood type O. And the left panel, the anti-A antibody, IgM, IgG. In the long-term follow-up, both IgM, IgG decreased significantly. Type B, the same. This is the same phenomena of significant decrease of antibody titer against donor type. This is another slide. This is anti-non-donor antibody titer and comparison with long-term titer against donor type. So just watch to the green arrow area. The antibody titer did not decrease. I mean, non-donor antibody did not decrease, even in the long-term follow-up. But in a red square circle, when compared with the blood titer against non-donor, titer against donor, the titer against donor significantly decreased, even the type A or type B, and both in the IgM, IgG. Consider the mechanisms. This is a hypothesis. So one is no inflammation despite existence of antibody. Another one is B-cell hyporesponsiveness, means low titer. Sometimes we encounter the patient who have high antibody titer, but nothing happened. So why? The one possibility is discrepancy between isohemoagglutinin assay and antigens on the surface of endothelial cell. Dr. Bentar reported that there were 6 subtype of antigen, ABO antigen, and 1, 2, 3, 4, 5, 6. And the vascular endothelial cell express only type 2, while the red cell can express from type 1 to type 6. If the hemoagglutinin assay catch the antibodies against all type, so but the vascular endothelial cell just only express only the type 2. So there might be some discrepancy between the amount of antibody which can attack the vascular endothelial cell and the result of isohemoagglutinin test assay. This is one hypothesis. This is another one. This is a experiment, role of liver sinusoid endothelial cell in induction of carbohydrate reactive B cell tolerance through the PD-1 and PD-L1 pathway. This group have worked on the role of liver sinusoidal epithelial cell on the T cell tolerance. So they reported the sinusoidal cell educate and the lymphocyte T cell in the liver graft. The same concept is introduced in these B cells. Left 3 is a cartoon of human blood type OAB, and the left one is posing GAL antigen. This is a similar structure. This is the cartoon of the experiment. There are 2 mice. One is GAL-T negative B6 mice. Red one is GAL-T positive B mice, a kind of wild type. So they isolate the liver sinusoidal endothelial cell from these mice and make a suspension. And there are 3 category 3 of mice. These are all GAL-T negative B6 mouse. The left one is complete control one, no injection. The middle one, the mouse injected with LC-EC suspension of blue, if it's negative mouse, through the portal vein. The right one is negative mice injected with positive suspension. Okay, and after that, they are immunized with gall-bearing rabbit RBC. This slide shows the expression of gall antigen on the endothelial cell. So the top panels are positive wild type. Of course, they can express the gall antigen. The negative one, of course, they do not express the gall antigen on the surface of endothelial cell. And injected mice with positive suspension express the antigen. And negative mice, of course, produce the antibody. Negative mice with negative suspension, of course, produce the antibody. But negative mice with positive sinusoidal cell cannot produce the antibodies. The hypothesis is right panel. So sinusoidal cell can modulate the activity of B cell. And they made another experiments. They activate the B cell with anti-IgM. And right panel shows that by stimulation, the B cell expressed PD-1. This is the hypothesis. And sinusoidal cell express PD-L1. If PD-L1 express the PD-L1, sinusoidal cell can activated B cell by PD-1, PD-L1 pathway. And they give anti-PD-L1 antibody to block the PD-L1. And they show the increase of antibody by PD-L1 blocking. This is the hypothesis. And the human sinusoidal cell can express the antigen, blood type antigen. So we have taken together, we have a hypothesis for the B cell tolerance. Okay. This is a completely different slide. When we follow up the patient after ABO incompatible liver transplantation, very often the patient forget that I had the ABO incompatible liver transplantation, something like that. So when such patient have encounter and a big injury, so sometimes they require the big surgery. So we have to do the transfusion. At that time, if we do not have the information about ABO, history of ABO incompatible transplantation, we give the patient with blood production of the patient's blood type. The red cell is okay, but if we give a lot of fresh frozen plasma or platelet, they contain antibodies against the graft. Although we do not have the report of acute AMR after a big surgery, a transfusion in liver transplantation, but already we have some case report of AMR by transfusion in kidney transplantation. So kidney and liver is has a big difference in the size. So some attack, liver can survive coming over some amount of the injury. And the kidney is very sensitive, so some difference. But we had better to avoid such situation. So in Japan, usually we give a small card to the patient. Please hold. On the card, I have the ABO incomplete transplantation. If necessary, please use transfusion blood type, AB, or a donor type. But the donor type is very difficult and confusing, so AB is easier. Now, the 14% of liver transplantation is incompatible in Japan. Okay. This is, do we have a time? Not yet, it is not published yet, but this is the result of the survey of Japanese ABO-I 2021. And this is the HCC one, just to show the only conclusion. There is no difference of survival and recurrence between ABO and ABO-I. This is another result of acute liver failure, adult acute liver failure. In this survey, 19 adult patients underwent ABO incomplete liver transplantation. Cause of acute liver failure, half unknown, and 21% drug-induced, autoimmune hepatitis 3, and hepatitis B 2. And this is the this slide shows when the patient received rituximab before the transplantation. Blue circle is the day of the transplantation, 2, the day before the transplantation, 4. The other one, red circle, is earlier than 3. And if we compare the incidence of AMR, here, and within the 1-day group, 50% had AMR, while the group before the 4 days, just 5.3%. This is the almost average incidence of AMR in a regular regimen group. And more important thing is these 6 patients did not have additional desensitization. No FK, no Cellcept, of course no time, and no splenectomy. And in a regular regimen, we quit the splenectomy already, okay? And in this group, they have a time, so FK, Cellcept. This lower panel shows the result of 10 years ago. At that time, only 6 patients had rituximab, but they did not have AMR at all. But all 6 had other desensitization too. 3 patients had infusion treatment and splenectomy. 2 patients had infusion. 1 patient splenectomy. Already, you are not familiar to infusion treatment. It is one of the game changer before the rituximab in ABO-I. Keep the small catheter in the portal vein or hepatic artery during the transplantation, and inject continuous injection with steroid, the prostaglandin E1 and the FOI, gabexate mesylate. And it also improved the result from the survival 20% to 60%. The rituximab improved the result from 60% with the infusion to 95 or 90%. Well, anyway, what I want to say is in acute liver failure transplantation and ABO-I, we need not only rituximab, but also other desensitization, at least splenectomy. Now, maybe IVIG after transplantation. And there, I heard today I have a basic scientist in the audience. This is a kind of new in DSA the field. A C1q binding antibody is a kind of common sense. The same thing is proven in the antibody against ABO-I antigen. My previous place where I was a professor of surgery, we had Tokyo Women's Medical University. We had a good immunology laboratory. We developed the system of measure the C1q positive IgG against blood type. And like this, and like this, and like this. This is the case with uneventful cause. The lower panel is the change of the IgG subtypes. The C1q positive and the red line is just low, nothing happened. This is the moderate AMR. The patient was rescued by just plasmapheresis and pulse steroids. The red one, please see the red one increased. The bar, just the titer, is only the 16. Okay. Usually, ABO titer increase, jump up to hundreds, thousands, and AMR occur. This is the classical scene which we encountered maybe 10 years or 20 years ago. But now, in rituximab era, the total amount of antibody sometimes is low, but AMR occur. And I found some indicator, and I encountered this C1q positive IgG against the blood type. And even though the total titer of the low, the red line is increased together with IgG1. IgG1 also capable to evoke the complement cascade. It's just a gentle AMR. This is a severe one. The titer increased but 128 at the first attack. So at that time, I was going to use bortezomib at that time, but committee of the hospital did not approve the use of bortezomib. Bortezomib is not approved by Japanese FDA yet, so we have to approval of the institution. But we can use the rituximab. Anyway, I gave the rituximab once the patient improved the symptom. But 2 months later, she had a second attack. The titer is very low, 32. But this is a line, the C1q is a thin green one, gray one. So it increase. The total number is very low, but I worry about the increase of the C1q titer. So at that time, I already obtained the approval of bortezomib. So I used the bortezomib. These phenomena is improved. But the patient developed the liver failure. Fortunately, we can save this patient 1 year after using the same blood type of the father. His age is 68. The reason why we rejected the father first is the age. But father's liver working very well. The patient is now happy with the children. So this is the figure of the severe AMR. You can see the coagulation of the and the red blood cell through the sinusoid and the swelling. And also right panel shows the sclerosing cholangitis and liver abscess. C1q binding IgG could be a good indicator in a low titer era. Thank you very much.